A warm welcome to today's talk. It's Sunday evening, the 31st of October. Now, I want to look today at people that get severely ill and hospitalised and even can die after vaccination. So quite an important topic, really. Get lots and lots of questions on this. Now, there's surprisingly little data on this. The CDC don't publish much data on it, and the authorities in the UK don't publish much data on this either. So it's really been struggling for data on this, really. But now this paper here, this was actually published last month. So I've found this in response to all these questions. And this gives us actually some it gives us some accurate data from Connecticut in the United States. And this is from the Lancet Journal of Infectious Diseases. So it's a fully peer-reviewed paper. You can download the PDF there, and it's great that these journals have managed to carry on allowing us to see these papers free, so they're available to anyone to look at, which is excellent. Now, getting straight down to the study, robust vaccine efficacy at preventing severe symptomatic disease is pretty well accepted. We know that all the vaccines, all the commonly used vaccines in the UK and the US and Europe, for example, all protect to a large extent against severe disease, hospitalisations and deaths. And we've looked at that for quite some time. But they don't prevent all cases of symptomatic disease by any means. And we looked at this just the other day. So we know that there's breakthrough SARS coronavirus 2 infections in the fully vaccinated. Just a couple of days ago, we looked at the COVID symptom tracker data on this, in fact. So this is everyone here. These are symptomatic infections in everyone, as we noted a couple of days ago, going up in the UK, needless to say at the moment. But these are symptomatic infections reported in people that are fully vaccinated. So we do see that there's quite a lot of infections, symptomatic infections reported in those that are fully vaccinated. That is definitely happening, and of course these are referred to as breakthrough infections. Now, what we don't know, what we didn't have so much data on, is the impact of vaccination on the admissions to hospital. So that's what this study is pretty well about. And of course, a lot of people are concerned that they have a particular age or particular comorbidity, and how likely is it that they're going to be severely ill, hospitalised, or even die from breakthrough infection. That's a pretty important question. So this study was patients with confirmed SARS coronavirus 2 infection. Now, it was taken from the Yale New Haven Health System, and the data was lifted from Connecticut. So that is this study, and as we said, peer-reviewed study. Now, it was taken between March the 23rd and the 1st of July 2021. Patients were considered fully vaccinated 14 days after their second dose, as we usually do. This is normal practice. Now, 969 patients were admitted who were PCR positive. So that was the number of patients admitted during this period of time. 172, that's 18% of the 969 patients, had received at least one vaccine dose. 103 had received a partial vaccine course. 15 had received a completed course. What they mean there by the completed course is that it had 2 vaccines, but it hadn't yet been 14 days after their second vaccine. And 54 were considered fully vaccinated with at least 14 days after their second vaccine. And there's actually a useful graphic here which shows that of the total admissions there, the 969, we see that 797 were unvaccinated. Partial course, 1 dose of vaccine was 103. Completed course, 2 doses of Pfizer or Moderna, or 1 doses of Janssen Johnson & Johnson, 15, but not yet the 14 days elapsed. And the fully vaccinated, 14 days after the complete course, these 54. So we see that the vast majority of patients who were admitted were in the unvaccinated group, and it gets much larger if we include those that had only had one dose of vaccine. Now, going on to look at the 54 now in more detail. Of these 54, among the 54 who were fully vaccinated, remember, 25 of those, 46 patients, were asymptomatic. So nearly half of the 54 were asymptomatic. Now remember, these were patients that admitted to hospital. So why were asymptomatic patients being admitted to hospital? Because it was an incidental finding that they were PCR positive when they were admitted for some other reason. So they were admitted to hospital for some other reason. The test showed they were positive, and that was 25 out of the 54 were there for non-COVID indications, in other words. So 25, 46 of the patients were asymptomatic. 4, that's 7% had mild disease. 11, that's 20% had moderate disease. But 14, that's 26% had severe or critical illness. And 7%, that's 4 of them, required intensive care. 4 patients required intensive care. 1 required mechanical ventilation with intubation, and unfortunately 3 died. And again, we can see that in this useful graphic form that's provided by the authors here as well. So these were patients that were fully vaccinated, looking at their disease severity. So these patients were incidental findings that were admitted for other purposes. 25 of those. Mild disease 4, moderate disease 11, but 14 severe or critical disease. So again, we see that vaccine is protective. A lot of these patients who were infected were asymptomatic, and of course the majority of patients who were admitted were unvaccinated. So it's not quite as bad as it sounds, really. The vaccines are clearly being highly protective. Now, amongst those with severe or critical illness, the median age was 80.5 years. So we see that age is a big risk factor for severe or critical illness breakthrough infections. So age is a big factor here. Older people are at much higher risk after 2 vaccines than younger people are after 2 vaccines. Pre-existing comorbidities were also present in most. Pre-existing comorbidities, and again, these are in the 14 patients with severe or critical illness. Now, body mass index greater than 25. So that was 9 patients. Now, what we would normally say is a body mass index of under, say, about 18.5. If it's less than 18.5, it's underweight. 18.5 to 25 we'll accept as normal. Over 25, overweight, and of course as it increases, 29, 30, 31, we're well into the realms of obesity. So overweight, 9 patients were in fact overweight out of the 14. Pre-existing cardiovascular disease, 12. Pre-existing lung disease, 7. Some form of cancer, malignancy, 4. Type 2 diabetes, 7. And immunosuppressive agents, taking immunosuppressing drugs such as steroids or drugs to prevent rejection of transplants, 4 patients. And of course, we can see that these numbers add up to much more than 14, so some patients had more than 1 comorbidity. Now, I just want to look at this this graphic here, actually, because this table here gives us some pretty fascinating information on this. So here we see all of the patients. So these were the patients who were in the severe illness category, or the critical illness category. And we actually see that the youngest of these 14, so this is the 14 here, we actually see that the youngest there was 71. And the oldest there was 95. So we clearly see this is happening in the older age group. Male and female, a bit of a mix. Body mass index, those that were, so we're looking for over 25s there really. So slightly overweight, obese, very obese, slightly overweight, over obese, very obese. So you will see that quite a few were overweight there. These are actually the outcomes. These patients who were discharged. These 2 patients unfortunately died, and that patient died, and that one was discharged. Now, this is the comorbidities here. This is the table of the comorbidities for these individuals. So, for example, this individual here who's 71 is a gentleman, body mass index, not overweight by any means, really quite thin. was discharged. Cardiovascular disease, yes, he had cardiovascular disease. Lung disease, yes, he had lung disease. Malignancy, no, he didn't have cancer. Diabetes mellitus, no, he didn't have diabetes. Immunosuppressive agent, no, he didn't have that. So that tells us that we see quite a few of these patients had several comorbidities. So we see that this patient, this had two comorbidities. This patient had four comorbidities. This patient had two more comorbidities. This patient had two comorbidities, and we see that most of that patient had three comorbidities. That patient had four comorbidities, and we see that as we go down. Now there was one patient here who sadly deceased. This patient died, unfortunately, and they did not have cardiovascular disease. They did not have lung disease. They did not have cancer. They did not have diabetes mellitus type 2, and they were not immunosuppressed. And this particular patient was a 76-year-old male. So this patient here, who deceased, didn't have any of the recognised comorbidities, but he was the only one. All of the rest had comorbidities. He had that patient there had three. That patient there had two comorbidities. That patient there clearly had four comorbidities. That patient had three. That patient only had one. That patient only had one. That patient had four comorbidities. So most had multiple comorbidities and were elderly. The exception being one patient who was 76. Okay, it's not young. And he was not overweight, and he didn't have any of the comorbidities. Now, frustratingly, we don't get any more information than that. It's interesting to assume, was there something else going on here? Was there a particular complication? Did he have a deep venous thrombosis resulting in a pulmonary embolism, as hospitalised patients can do? We simply don't know. Frustratingly, we're not told. But this is just one patient out of this whole grouping. So we see that most patients are elderly, most patients have multiple comorbidities. So lessons that come out of this, I think perhaps the most important question here is that comorbidities need to be as well managed as possible. We believe that the better managed a comorbidity is, another disease is, if the heart disease is well controlled, if the lung disease is well controlled and the patient stops smoking, if the diabetes is well controlled, if the hypertension is well controlled, then hopefully these patients would do better. But I think that's fairly clear there, that the vast majority of patients are much older and much more likely to have several comorbidities, at least one comorbidity, or indeed, in the majority of cases, as we see there, several comorbidities. Now, just one more thing I want to get out of this paper here. Differences between vaccines. Now, this is interesting. So 13 of the 14 patients, of the severely ill or critical patients, 13 of the 14 had received the Pfizer vaccine. One had received the Moderna vaccine, and none had received the Johnson & Johnson vaccine. Interesting. So we know that breakthrough infections are more common with the Johnson & Johnson Janssen vaccine. But that's breakthrough infections, whereas here it's saying that none of the patients who had the Johnson & Johnson vaccine, no one who was severely or critically ill had been vaccinated with the Johnson & Johnson vaccine. Remember, this is just one dose. So even although breakthrough infection is more likely, from this it looks like that the severity infection is not likely to be severe. Now, we have to qualify that, and we will do in a minute. But 13 of the patients had the Pfizer vaccine, and only one had the Moderna vaccine. Now, how do we explain this? Well, of course, the booster dose, if people are getting a booster dose of Moderna, they're only getting a half dose, the 50 microgram dose. The initial, sorry, did I say that right? People that are getting the Moderna booster, they're only getting a half dose. They're getting the 50 microgram dose of Moderna rather than the 100 microgram dose of Moderna, because the 100 microgram dose of Moderna was the first and the second vaccine. So it was a higher dose, whereas the Pfizer was only 30 micrograms. So it looks like some people now think that the Moderna dose was probably a bit on the high side, But while that might, and a stress might make vaccine complications more likely, it seems to offer high levels of protection against severe disease, critical disease. Now, frustratingly, again, the study doesn't tell us more on that, but this definitely merits more study into that to explain that difference. Is that difference widespread? Is it the same everywhere in the United States? Is it the same everywhere in the United Kingdom? Well, from this study, of course, we don't know, because this was simply data on Connecticut. So more data required on that, but that's certainly a very interesting lead for researchers to start looking at. Let's hope they do. And none had received the Johnson & Johnson vaccine, which looks pretty good. Now, but to make sense of this, though, we need to look at the proportion of vaccines that had been given out. Now, this was only up to the 17th of May where this information was available. Now, Pfizer and Moderna have been given in large amounts. So 1.3 million Pfizer's, just over 1 million Moderna, but just over 250,000 Johnson & Johnson. So less Johnson & Johnson have been given out. So that puts us this in some sort of context. But it is showing that people had less severe critical illness and death after the Moderna, more after the Pfizer, and less after the Janssen Johnson & Johnson. So there we go. I think the main takeaway from that is that people that have are aged in these categories, this older age grouping, are much more at risk of severe illness, critical illness, and unfortunately some risk of death. And these patients very predominantly have multiple comorbidities. A couple of patients only had one comorbidity, and only one patient here didn't have these particular comorbidities. We're not told if he was hypertensive or had other disease. We simply don't know that from this data, frustratingly. The data only tells us what the data tells us, and we take a bit of a risk if we go beyond what the data tells us. So I thought that was quite interesting. That's the risk. So most people at low risk of severe illness and critical illness, if they are younger and especially if they don't have comorbidities. Now, just before we go on to Mike's report from New York City, a couple of frequently asked questions. Now, this is about me, so a lot of people have asked, have I had my booster yet? The way it worked out, I was supposed to get a first dose of Oxford AstraZeneca vaccine, but I was called in before time because there were some Pfizer vaccines left at my local surgery. So I had my first and second dose of Pfizer vaccine, and I had those 12, was it 11 or 12 weeks? I think it was 12 weeks apart. So quite a long gap between those two. Have I had my booster yet? No. So my second vaccine was in May. UK protocols say 6 months after the second vaccine to get a booster. So I'm due my booster in about 2 weeks' time, sort of middle of November. So thank you for asking. I am making tentative inquiries about getting it aspirated. I was talking to a registered nurse today who got a vaccine from a local high street outlet, and she told me that she asked the pharmacist if he would aspirate, and the pharmacist said, does that mean you inject water before you inject the vaccine? So I do find it concerning that someone who's giving vaccinations doesn't even know what aspiration means. It's strange that we're getting people to give injections who don't know anything about giving injections. That's a little bit surprising, and to be frank, quite concerning. But I think Mike's going to comment on this in a minute, so I won't comment more. Now, another frequently asked question from yesterday's video, when we looked at the antidepressant, of course, the fluvoxetine, and the reduced risk of hospitalisation and deterioration in COVID-19 in patients with a risk factor. So the question is, does the drug itself help, or does being in a more positive state of mind help the immune system? Now, that is a good question. That's a good question. I had a lot of similar questions to this. Now, I think the answer to the question is being in a positive state of mind does help the immune system. Or I think what I could say more scientifically is having low stress levels helps the immune system. Having high stress levels reduces the efficiency of the immune system. I think that's pretty safe to say that. So does a positive frame of mind help immunity? Yes, in that you're likely to be less stressed. But of course, this fluvoxetine was only given for 10 days, and for an antidepressant effect to kick in, typically takes 2, 3 or 4 weeks. So given this 10-day course, these patients would not be experiencing an antidepressant effect from the fluvoxetine. They would have to take it for longer. So I think we can answer a fairly definitive no to that part of the question, although the answer to the question is yes, in generally speaking, lower levels of stress are associated with better levels of immunity, but that would not be a factor after only 10 days of selective serotonin reuptake inhibitor antidepressant. Now I want to go over to Mike now in New York City. Mike, thank you very much for sending this report in, and over to you, sir.
Hi, Dr. Campbell. This is Mike in New York City. I am doing this video to relay my experience with getting my booster shot for the Pfizer vaccine and asking for the nurse to aspirate before injecting the vaccine in. About 2 months ago, when I had my last checkup with my doctor, I asked him about aspirating, and he knew all about it. He said, we don't have to do it, but if you want it, that shouldn't be a problem. And also the nurses that worked there, they all knew what aspirate meant and would do it if requested, but they wouldn't do it normally if it's not requested. So I felt comfortable with that, and then when I was ready to get my booster shot, which I got 2 weeks ago, I was going to do it with my doctor, but I needed to make an appointment, which would have taken like 3 weeks, 4 weeks, and the pharmacy by me, CVS, they could do it even that day. They said just go online and schedule an appointment. So I figured I'd take the quicker way because I wanted to get it over with, plus get the flu shot with it as well. So I did that. When I showed up, the nurse that came out to administer the injection, I asked her, I said, could you aspirate before the Pfizer shot before injecting it? And she said, you mean pulling the plunger back? I said, yes, yeah, and then to let air in the syringe. And I said, no, not that. So in my head, I did a gasp. I could see she didn't know what it was. So I went on to explain to her what aspirate meant. And so I told her, and I thought it was simple English to say, you stick the needle in where you're supposed to. Before you push the plunger in, you pull it out a little bit to see if blood comes out. And if blood comes out, you know you hit a vein and that you have to take the needle out and then reinsert it at another spot. And then she said, oh no, you can't, you don't do that with these syringes. This is a vanishing point syringe, which I had no idea what that meant, other than that it may have meant that the needle retracts. She explained to me that when you do it, the needle retracts and then you can't use it again. And I said, but this is before you do the injection. And she says, yeah, it will detect that. And so I was very skeptical of what she said, which kind of led to the idea that if the needle hit a vein, that it would retract automatically. So I questioned it further and said, do you mean that if you stick the needle in and it hits the vein, it will automatically retract? She said, yes. And I was flabbergasted at that response. I didn't believe it, but at that point I felt pushing it any further, she might do more harm to me. I don't know what harm could happen if you aspirate incorrectly. And so I went through, got the 2 shots, then I went home and I looked online who makes the vanishing point syringes, which is made by Retractable Technologies. I went to their website, got a phone number, called up their customer service line, and I asked the woman that took my call about the syringe, and I said that, and I asked her specifically, if that syringe pierces a vein, does it detect the vein and automatically retract, or is this only retracting when after you inject the vaccine? And she says, it doesn't retract if it hits a vein. We said, we don't make any syringes like that. We don't make any claims like that. And she says, I don't know of anyone that does, because I thought if it did, that would be quite amazing if they did have that technology, but I doubted it. So this nurse that gave me the injections, I don't think she was trying to mislead me, but I don't think she was well informed, and I think she was just lacking in experience, any kind of experience. So I think that's what most people are going to expect if they don't go to their doctor's office or a hospital. And I kind of suspect that because of the pandemic, they brought in a lot of people to do injections that are not fully trained nurses yet. Maybe they're fresh out of school, or people that are not really in an area of nursing where injections is a commonly done. Who knows? I mean, I just don't think that a lot of the pharmacies and these vaccination centers probably have less qualified people than if you go to a doctor or a hospital. Although the hospitals here, at least the public hospitals, they're in a pandemic mode where all of their skilled nurses are working with ICU units in other areas of the hospital that they need more skilled people, and vaccinations. They've been deferring vaccinations to go to these vaccination centers, which happen to be mostly pharmacies and some special centers that just do the vaccinations. I heard your comment after the guy that mentioned his experience at Walmart, that you gave kind of a groan over that. I can only imagine what you'll think about what my experience was. And so if you really want to aspirate in the U.S., go see your regular doctor for that, instead of going to a pharmacy or someplace like Walmart, where the people there are less skilled, less educated, or whatever. I don't know. Okay, well, that's all I have to say. Thank you,
Mike. Thank you very much for that. That's I made a note there, making things up. So a theme here seems to be that when people are asked about vaccination, like that doctor from New Zealand, and it's not just him, not just picking on him, like the question to the Irish Parliament, but if they don't know the answer, they tend to make something up which is often quite absurd. So here, this person that was given the injection said that if you hit a vein, it just automatically retracts. Well, that's just rubbish. Those syringes, I think what those vanishing point syringes are, once you've given the injection, the needle retracts, so you can't stab yourself on the dirty needle. So people making things up. So that's a bad experience, or let's say an experience where the clinician completely failed to answer a basic question in the United States and in a pharmacy in the north of England. All you have to go to do is stick it in, draw back, stick it in, draw back. If you're not getting any blood in, then you can inject. It's it really is that simple. So what the pharmacist in the UK thought aspirating was injecting water. This person giving the injection in the United States, in Mike's experience, seemed to think it was putting air in. Yeah, I'm just, as Mike says, I'm flabbergasted. Mike, thanks for that report. Great report, very clear. And thank you for watching this video.